Hello, my name is Dr. Nathan Parker, and today I will be talking to you about a quality improvement project at St. Joseph Mercy Hospital, Ann Arbor, surrounding the implementation of our Obstetrical Enhanced Recovery After Surgery program. I have no conflicts of interest. Within the last 2 years, cesarean sections have made up nearly 32% of all deliveries, according to the Center for Disease Control. This accounts for around 1.2 million cesarean deliveries a year in the United States alone. National trends from the past decade suggest that on average 5% of these deliveries are complicated by surgical site infection, a morbidity leading to prolonged recovery and hospital resources. To acknowledge this burden on our patients and healthcare system, perioperative enhanced recovery after surgery protocols have evolved. This quality improvement project sought to understand if our obstetrical ERAS bundle decreases surgical site infection rates after cesarean section. Case-specific variables that were tracked included maternal age, BMI, unscheduled versus scheduled cesarean sections, and the presence or absence of chorioamnionitis. Our obstetrical ERAS bundle included 3 areas of infection prophylactic intervention: the immediate pre-op, intra-op, and post-operative time periods. Preoperatively, surgical site prophylaxis involved patient education to shower the night before and the morning of scheduled cesarean sections. For all cesarean section pre-op, chlorhexidine 2% body wipes were used and 4% chlorhexidine abdominal prep was standardized. Additionally, clipping, not shaving, of the intended skin incision site was performed. Intraoperatively, as has long been the standard of care, weight-based cefazolin was used for antibiotic prophylaxis. The addition of azithromycin for unscheduled cesarean sections was used where labor or rupture of membranes had occurred in the absence of chorioamnionitis. Redosing of prophylactic antibiotics every 4 hours during the procedure, and if the quantitative blood loss was greater than 1,500 milliliters, was practiced. Additionally, standardized vaginal prep and changing to a secondary sterile closure set, including glove change at time of fascial closure, was also employed. Postoperatively, patients were educated on daily incisional cleaning after the dressing was removed, 6 to 12 hours post-op. Interdry moisture-wicking antimicrobial fabric was used if abdominal pannus was present, and additional patient education was undertaken to encourage compliance with removing steri-strips 1 to 2 weeks postoperatively. Initially, all patients who underwent cesarean section at St. Joseph Mercy Hospital, Ann Arbor, between January 2018 and December 2019 were considered in our QI project. As it took 6 months for full implementation of our ERAS bundle, the 399 patients who underwent cesarean section during these months were excluded. After this exclusion, a total of 1,672 patients met criteria for our cohorts: 787 patients in the pre-intervention and 885 patients in the post-intervention cohort. Data variables taken into account included maternal age, BMI, chorioamnionitis, unscheduled cesarean delivery rates, and surgical site infections within 30 days of the procedure, as defined based on the CDC's National Healthcare Safety Network criteria, which is readily available online and tracked through the NHSN MedMine LLC databases by our Infection Prevention and Control Services. Overall, cohorts were well matched, with maternal age, BMI, presence of chorioamnionitis not statistically different between groups. An exception was seen in a significantly greater number of unscheduled cesarean sections in the post-intervention cohort. With regards to our primary outcome, there was an absolute decrease in surgical site infection after our obstetrical ERAS bundle implementation. However, this was not statistically significant with a p-value of 0.61. On multivariable regression, the ERAS bundle, maternal age, in a secondary analysis when subdividing surgical site infections into superficial and deep, as well as examining surgical site infection readmission rates, there were not found to be significant differences between the pre- and post-implementation cohorts. In conclusion, after implementation of our hospital's obstetrical ERAS bundle, an absolute decrease in the frequency of surgical site infection was noted, though not statistically significant. This is in the context of an already very low post-cesarean surgical site infection rate at less than half the national average. As this was a quality improvement project, it was not assessed for power, and thus designing a future research study with adequate power may yield results of greater statistical significance. Additionally, inclusion of other patient-specific surgical site infection risk factors may provide a more tailored approach to our obstetrical ERAS protocol and its effect. Finally, continuing to develop protocol adherence strategies and tracking differentials in cost among bundle items are all worthwhile endeavors. I'd like to take a moment to acknowledge the contributions of the following individuals and committees, as this project would not have been possible without them. Here are my resources, and thank you for your time.